because otherwise it's a very long video.
Yeah, I think it worked out.
Andrew, my apologies. I may be hopping on and off, but I will be listening. I just will have my camera off for much of it.
No worries.
But thank you for doing this.
Yeah.
We can go ahead and get started. Andrew, thanks for being here. Andrew is an R2, part of the clinician educator pathway. I've heard his talk this week, so I'm very excited to hear it again.
Like I don't know higher praise than that, Karen. Willing to hear an academic talk twice in the same week. So, guys, I'm Andrew Gonzalez, R2, as we said. This is going to be an outpatient guide to gout. I did a little inpatient things, a couple slides, just because I couldn't help myself. I have no conflicts of interest. I can be bribed, although because this is being recorded, I will clarify that's a joke. My goals are to introduce physicians at every level to important concepts of managing outpatient gout. Some of the objectives we're going to cover today, as far as that is concerned, the pathophysiology of gout, risk factors for gout flares, how to make a formal diagnosis of gout, identifying and managing acute flares, as well as, hey, when do we start and why do we start urate-lowering therapy in gout? And what are some considerations we have to take in our patients with multiple medical comorbidities who are being treated for gout? So introduction to gout. What is it? Gout is a disease where you have a deposition of monosodium urate crystals in the joints, bones, and soft tissues. The crystals themselves accumulate because the normal solubility of uric acid is about 6.8 milligrams per deciliter. Above that concentration, you start to have precipitation of crystals. I'm speaking to a group of people who took at least a high school versus college level chemistry class. We all had to titrate our beakers and whatnot. The crystals accumulate in those areas. They trigger inflammation through several biochemical mechanisms. And that inflammation is what causes the symptoms of gout: redness, swelling, intense pain, which leads to presentation. What's going on a more biochemical level? Well, this is an innate immune system mediated process with neutrophils and macrophages responding to go in and attack the crystals at the level of inflammation. It also involves the inflammasome, everybody having flashbacks to MS 1 year and having to know what the heck that is. You're welcome. They stimulate an interleukin-1 release, stimulate the inflammasome that causes all the downstream reactions of inflammation. And then the chronic inflammation itself from the crystals and the immune cells cause osteoclasts, osteoblasts, chondrocytes to develop, gouty tophi, which we'll get into, bone erosions, cartilage breakdown, all the long-standing joint injury that we're trying to prevent when we treat gout. The number one risk factor for all of this is hyperuricemia, high uric acid levels in the blood. So why so much uric acid? Uric acid is a byproduct of purine degradation. So it's going to be natural, as just part of our natural metabolism of creating and just DNA. It also comes in through our diet. So the bottom line for gout is you're having gout from that hyperuricemia, either because of an overaccumulation of uric acid, because you either can't excrete it, such as in chronic kidney disease, or you're having a situation of high cell turnover, like certain cancers, where cells are dying, pouring out the internal uric acid, causing too much uric acid to accumulate in the bloodstream. An alternative for that increased uric acid production is too much uric acid intake through taking in foods and such that have too much uric acid. Also, just certain individuals you have abnormal purine metabolism through certain X-linked abnormalities, such as Leishman syndrome, really taking it back to step one there. And an important thing I want to highlight here, though, is although hyperuricemia is the #1 risk factor, people can have a normal uric acid level and still develop a gout attack. Also, conversely, some people just out there have super, super high uric acid levels and never once have a gout flare. I know I've had like multiple people come into me in my continuity clinic. They just happen to have their uric acid tested for whatever reason, not having ever had a flare in their life. They're like in their 20s and they're asking me, hey, do I have gout? No, you do not have gout. You need to have a flare in order to qualify for that diagnosis. 20% of the US population has asymptomatic hyperuricemia. I just want to point that out. And then this is a analogy that I ripped off basically from Curbsiders, just because I think it's a very astute presentation of what is happening in a gout flare. So the tub is your body, your joints. The water in the tub is your uric acid level. And either you're having too much production of that water, which would be like overproduction, over consumption of uric acid, or the drain is clogged, meaning you can't excrete it, like renal insufficiency. And once that water level gets too high, shorts out a nearby electrical conduit, and that's the gout flare. Mentioning this analogy because I'm going to come back to it later when we talk about urate-lowering therapy. What are the risk factors for gout? So we like to quantify or categorize these into modifiable and non-modifiable. So modifiable risk factors are things like obesity, hyperlipidemia, things that we can modify, treat either with lifestyle interventions or medications. Along with that, increase alcohol intake. Interestingly, beer is a bigger and hard alcohol are a bigger risk factor than wine as far as alcohol intake. Beer can increase your uric acid level by like 18 to 20% just by itself from having a couple drinks of that. High fructose corn syrup, usually taken in via soda, is a big propagator of gout flares. Diets high in purines, meaning red meat, organ meats, shellfish, things like sardines, super high in uric acid. Those are big triggers for people for flares. Uncontrolled disease states like leukemia, psoriasis, congestive heart failure will trigger a flare. Certain medications, which I'll specify soon, but like diuretics and chemotherapy trigger gout flares. And also, just for consideration when you're seeing this in an outpatient setting, dose changing your urate-lowering therapy can, in the immediate period, cause a patient to have a gout flare. Then we go into our more non-modifiable risk factors. Some people are genetically predisposed to having more gout flares, usually higher incidence in like Asian Pacific Islander populations, males, older age, postmenopausal people. Estrogen stimulates renal excretion of uric acid. It's uricose uric, as we say. Chronic kidney disease, even if you are treating that, managing that well, you're still going to have just baseline urate clearance deficiency. You're going to have more risk of gout flares. And things like recent surgeries, infections, stress, trauma, anything where you're overburdening the body, you're going to have more risk of a gout flare. So what are these medications I'm talking about? Because medications are what we're using most of the time. It's going to be both a consideration in outpatient and inpatient patients. So things that increase uric acid, niacin. You don't think of vitamins as increasing uric acid maybe, but niacin is one of them. Pyrazinamide and ethambutol in our TB treatment patients. Thiazides definitely. They cause the kidneys to reabsorb urate, beta blockers, ACE inhibitors, chemotherapy like cyclosporine or tacrolimus. And interestingly, aspirin, even though it's an NSAID, it has a paradoxical effect on the urate level. Low dose aspirin, less than 2 grams, will increase uric acid levels. But not all medications are, offenders of gout. Some of them are tangentially helpful. So, for instance, decreasers of serum urate are calcium channel blockers. Both losartan and fenofibrate are uricosuric, so they make you pee out more uric acid. And SGLT2 inhibitors are theorized by their glycosuric effect to also have increased uric acid secretion, given that they're the shared transporter. Okay, so what does an acute gout flare look like, Andrew? I'm kind of beating around the bush to getting to how this patient is going to present to us. So they're going to come in with usually a few hours of swelling, pain, and erythema of a joint. Typically, it's a joint with maximum severity reached within the first 12 to 24 hours. Usually, these flares occur at night because gout itself is the crystals themselves precipitate more often if at lower temperatures and with relative dehydration that you'd find at nighttime. Intense pain, sometimes out of proportion to exam, not to make you concerned of necrotizing soft tissue infection, but I just want to paint the picture that a gout flare is exquisitely painful. And usually monoarticular one joint, although over the natural course of a person having this disease, if uncontrolled, they can start manifesting gout flares in multiple joints at once. And those joints are typically the first MTP, that big toe right there pictured. That's what we call podagra, which is 90% of people will have involvement of the big toe at some point in their history of having gout. And about 80% of all flares are going to come in a lower extremity joint. Remember, these flares occur usually at lower temperatures. The farther away you are from your core, usually the lower temperature you're going to have your in that area of the body. But you can also get flares in the wrists, elbows, small fingers. Really can be any joint, although the first MTP is the most common. And if untreated, a flare can last 1 to 2 weeks if you're not giving any therapy. So keep that in mind because that's a long time to just have somebody just be in pain. So steps of a gout attack, just because I'm loving my pathophysiology. Deposition of urate crystals causing inflammation and vasodilation. That allows your neutrophils, your immune cells, to get to the area. They phagocytize the crystals, lyse, release the proteolytic enzymes, which is responsible for the pain, swelling, erythema, what have you. So differential for gout flare, first of all, gout, like duh. Second of all, calcium pyrophosphate deposition looks a lot, aka pseudogout, looks a lot like a gout flare with swollen joints. Differentiator between that is, I'll get into it, in arthrocentesis, those crystals look differently, as we all remember from our step 1, step 2. Those are rhomboid crystals, while gout crystals are needle shaped. But also, and this is an important one, a septic joint or cellulitis, you really have to have a high suspicion of infection whenever somebody presents with a gout flare, because some of our therapies that we're going to use are going to worsen infection if we're not absolutely certain that that's not co-occurring. Just for broader differential, this is somebody you never met before, always consider autoimmune diseases like psoriatic arthritis and RA, and just be extra certain that a gout flare is a gout flare. So the diagnosis itself, the gold standard for gout diagnosis is arthrocentesis, but frequently you can diagnose a gout flare clinically. As I mentioned, you just have to have a high suspicion if you're going to make that just solely clinical diagnosis that we're not concerned about a septic joint, meaning that the patient's not having fevers, not having any recent trauma to that joint with skin perforation, not having an elevated white count on CBC. Because if there's any suspicion whatsoever of a septic joint, you should pursue an arthrocentesis to rule that out. And what are you going to see on that arthrocentesis? You're going to see gout crystals, as mentioned. Your keywords: negatively birefringent needle-shaped crystals. What does that mean? You put the slide under with a polarizing light under it, run the light parallel to the crystals, they should appear yellow. But don't be surprised as well that you see neutrophils in that joint, up to 10 to 50,000, if not more neutrophils, because remember, they're coming in to attack those crystals, respond to the inflammation. And what you need to have to rule out a septic joint is a negative gram staining culture. You need to make sure that's obtained before doing something like an intra-articular injection to treat a gout flare. The presence of crystals alone do not rule out the septic joint. You can have both a flare and an infection at the same time. Remember, infection is a risk factor for causing a gout flare. So, but Andrew, you're talking a lot about clinical diagnosis before. How do you make that clinical diagnosis? Well, some of the things that you're looking for are history of gout attacks, monoarticular presentation, usually in the lower extremity as mentioned. Remember, 90% is in that big toe, so have that high suspicion if it's in the first MTP. But you can also have bursitis, tendonitis. Patients can present with hyperuricemia, but of note, during a flare itself, that uric acid level may be artificially depressed because all that uric acid is accumulating in the joints as crystals. And there are some characteristic imaging results, which I'll show you in the next slide. Although you don't necessarily need imaging results to confirm the flare, they can be helpful in both ruling out other things like fractures, trauma, or in monitoring people with chronic gout to see if they have like joint erosion. So radiographic evidence on X-ray, you're going to see what we call rat bite erosions, which are that kind of bitten out punctate lesion you see over here, where the joint space itself is preserved, but the surrounding bones kind of get wasted away by the inflammation associated with gout. And then for those of us who have any experience in joint ultrasound, there is a telltale sign called the double contour sign, where when you're taking the ultrasound to the joint itself, you're going to see basically a double band along the articular cartilage line. And that second band you see is from the deposition of the urate acid crystals, causing the two strips to come out on the ultrasound. You may be asking, but other than my clinical gestalt, is there any kind of rules or tools that I can use to, really nail down that this person has gout and not something else, other than, taking a needle to a joint? Yes, there are. Otherwise, I wouldn't have mentioned it like that. There's something called the acute gout diagnosis rule, originally validated in Europe. So not well studied, but not necessarily, with that caveat of, applying it to non-European populations. Can help guide you if you're on the fence about, hey, I don't really feel strongly that this person needs a synovial fluid collection. And by study, it's proven that it's positive predictive value when compared to just your instinct, your clinical gestalt. Clinical gestalt has a positive predictive value of like 64%, whereas adding the rule can up that to like 87%. And negative predictive value goes up from 87% to like 95% when using acute gout diagnosis role. There's also a related tool called the ACR EULAR gout classification criteria, which is specifically made for making diagnosis of gout when, for whatever reason, you don't have the tools available, you're not able to tap a joint because it's too small. You need an expert to tap an MTP by itself. And you can't get that synovial fluid for whatever reason. So the tool itself looks like this. It's basically a tiered system of based on points with associated risk factors and associated presentation with physical exam, kind of grading whether you have high, low, intermediate, or high suspicion of somebody having a gout flare. And if you have no indications for arthrocentesis, and you do this, and that person has above those 8 points high suspicion of a gout flare, it's okay to go along with treatment without having done the arthrocentesis. Before I go into my next part, anybody have any questions? No, I'm talking a lot. Might take it as a no. Let's go. So, how are we going to treat an acute gout flare? The best time to start treatment is within 24 hours of symptom onset. The goal of the treatment is to decrease that inflammation and that pain. And the tools that you have are NSAIDs, oral colchicine, and glucocorticoids. And important, if somebody's already on urate-lowering therapy, keep it going while they're having a gout flare. Not the last time I'll say that point. Okay, so NSAIDs. Being a big nerd, mechanism of action for NSAIDs, they are COX inhibitors, which causes you to not make prostaglandins, which are a mediator of inflammation. Cool. I'm insulting my own writing. Some of the options you have, you can use naproxen, indomethacin, ibuprofen. Usually you treat with high doses for 3 to 5 days, and then just be conscientious after that 5-day marker. You cut the dose in half if somebody's still having a flare. If you're going to use, these long-term NSAIDs, keep in mind whether somebody needs GI prophylaxis, start a PPI, famotidine, what have you, because you're going to give somebody an ulcer. Remember, even though it's technically an NSAID, no aspirin, no salicylates, they have a paradoxical effect on the uric acid level. This does not mean you take secondary prevention off of your patients who have CAD, stroke, what have you, who also have gout. You need to keep risk-benefit in mind. It sucks that you're having a higher risk of triggering a flare, but it's also way suckier to have a heart attack. And it's also proven in studies that it's okay to continue somebody on aspirin if they're already on aspirin during an acute flare. Some considerations for NSAIDs, you shouldn't really be using them in CKD, shouldn't use them in cardiovascular disease, GI disease like peptic ulcers, and shouldn't use them in people on chronic anticoagulation or bleeding risk. So what do we use for that? Well, when in doubt, you have colchicine. Mechanism of action for colchicine, it works on thanks, Connor. Mechanism of action for colchicine, it works by disrupting cytoskeletal microtubulin. Basically, fancy word for saying neutrophils can't get to the area and neutrophils don't work at the area. But that is why it's super, super important to remember that colchicine really only works if it's dosed within the first 24 hours of a gout flare, really before that flare hits its peak. Why? Because you really want the colchicine to prevent the neutrophils from getting to the area of urate crystal deposition. If the neutrophils are already there, they're going to be dying, they're going to be causing inflammation, you're going to have worsening flare. And the way you dose colchicine is usually give them 1.2 milligrams an hour later, you give them another 0.6, no more than 1.8 milligrams the first day. And then during the course of the flare, give them 0.6 milligrams twice a day. If a patient, I'll talk about prophylaxis and urate-lowering therapy in a minute. But if a patient is already on colchicine, make sure that even after the flare is done, you keep them on their dose of colchicine. That's going to be usually like that 0.6 milligrams twice a day going forward. Some consideration for colchicine. Why don't we use it for everybody then? Well, it's not a magic bullet. It has side effects. Usually you'll have people say they can't tolerate it because of really bad diarrhea, really bad nausea, and people with who are already on statins, there's risk of myopathy and rhabdo. And some other considerations for colchicine: if people are on carvedilol, it can increase the level of colchicine to toxic levels and definitely worsen diarrhea and nausea. It's metabolized by liver enzyme CYP450. So that interferes with a whole host of other medications, diltiazem, verapamil, fluconazole, macrolides, all of those, and can lead to toxicity of these medications. It does require renal dosing. Really shouldn't use in people with hemodialysis. We usually think, hey, the hemodialysis will wash it out. No, it does not wash out colchicine, and therefore can experience toxicity. And also would use in caution with people with hepatic dysfunction. It's a liver metabolized agent as well. And then when at a loss for whatever you can use, you always have your magic bullet, your glucocorticoids, which you can give either oral, IM, or intra-articular. Oral dosing for prednisone is about 30 to 40 daily during a flare, and then would gradually taper after the flare's resolution, not because you're worried about HPA axis muting. You need at least like 3 weeks of constant glucocorticoids before you start having your adrenal glands stop producing steroid. More because in the acute period after a flare, you can have rebound flares. So doing 40, tapering it down by 5 a week. I know we always refer to like rheumatologists and people for like, hey, what is the taper going to be? And I'm an R2, I'm not an expert, but in my experience of speaking with every rheumatologist I've ever met about how do you pick a taper, it's usually just kind of, this worked before. Go down by 5, go down by 10. That's not me trying to tell you not to get rheum involved. That's just me saying it's not an exact science, or as far as I know. Feel free to correct me if I'm wrong. Also, you can use IM triamcinolone. Of course, this talk is focused on outpatient gout. I realize you can see when I do that. This talk is focused on outpatient gout, so logistically probably makes more sense for somebody to be on oral prednisone unless they're admitted. Intra-articular glucocorticoids are a third option, usually, again, triamcinolone, 40 milligrams, in a large joint, 30 milligrams in a medium joint like a wrist, 10 milligrams in like a small joint. Usually most efficacious if you have 1 to 2 joints involved. Otherwise, more than that, we'll just use an oral or an IM solution. And remember, to stress the importance of ruling out septic joint, it was important to rule out septic joint when we're just trying to treat a gout flare to know if we have to get, like, let's say, ortho involved for a washout of the joint. It's even more important to rule out a septic joint when I'm literally injecting immune dampening medication into the site where bacteria could be. So if at all you are thinking about doing an intra-articular glucocorticoid injection, before you do that injection, get the sample. get the culture, get the gram stain, make sure that they do not have bacteria in there. Otherwise, you're going to destroy that person's joint by doing a joint injection. As always, not to harp on, but yes, that's a very important thing. Considerations for any time you give steroids: hypoglycemia, steroid-induced psychosis, insomnia. Really want to avoid steroids in CV disease, diabetes, GI disease like peptic ulcers, infections, and in the postoperative period, because that can interfere with wound healing. Okay, so that's how we treat an acute flare of gout. But just a word on inpatient options, couldn't help myself. You can use anakinra. These two medications are both IL-1 inhibitors, so they stop the inflammasome from turning on. You can use anakinra in our hospitals. Need a room consult if you're considering that. But it's a good thing to have in your back pocket if they have a lot of contraindications like congestive heart failure, CKD. Canakinumab is one I learned about. It's really only available in the EU. And I won't say more on that because we're not using it yet, if at all. What does gout kind of progression look like? Well, first stage is the hyperuricemia. Remember, you need hyperuricemia with a gout flare in order to really have that be the diagnosis. Then the person will have, a period of like acute gouty arthritis, usually monoarticular flares. In between the flares, they'll have an asymptomatic period, which we call the intercritical period. And then if really not controlled gout, you can end up with tophaceous gout, which is a late complication of gout, where you end up with depositions of uric acid crystals in joints and soft tissues called gouty tophi. I'll have a picture of that in a minute. That leads to joint deformity, destruction, nerve compression. It's uncommon in general, but is a concern that we want to mitigate by treating gout. And the most common sites of those tophi are in fingers, the olecranon. It can deposit the Achilles tendon, knees, what have you. They look like this. Usually a lot in the bursa. Small joints of the hands could have that kind of pearly, like little yellow appearance. Usually not painful, funny enough. So if something's like really giving somebody an issue, I have an even higher suspicion of like cellulitis or septic arthritis. But this is something that happens if you're not treating gout appropriately. Oh God, Andrew, how do we treat gout appropriately then? You lower the uric acid. Gout, the goal is to reduce the prevalence of flares and prevent erosive disease like these tophi from occurring. First thing you should do is lifestyle modification. If they're not taking alcohol, treat alcohol use disorder. Well, that doesn't have to be alcohol use disorder. Like I said, like even a beer or two. You really have to hammer down that they need to cut out the triggers: alcohol, red meat, things that are giving them issues. If they're on thiazide diuretics, think about different diuretic use that you could use for preventing gout flares in the future. And if non-responsive to lifestyle modifications, then we start thinking about urate-lowering medications if they fit criteria. That criteria being the ACR guidelines for uric acid lowering therapy, ACR being the American College of Rheumatology. They strongly recommend urate-lowering therapy in anybody with tophi, the erosions on X-ray or ultrasound, 2 or more attacks a year, and to consider these medications in people who are having at least one flare and CKD3 really high serum urate above 9, or people with kidney stones. Remember, don't use it in people with asymptomatic hyperuricemia. So what are our agents? This is where I come back to, oh, dang it. I like gravitas. Don't start uric acid lowering therapy acutely because you can worsen or precipitate a repeat attack. Wait 1 to 2 weeks after the flare onset to start your urate-lowering therapy. Again, keep it going if they're already on it when the flare occurs. Interestingly, the American Academy of Physicians don't have any goals for urate-lowering therapy. They don't say, treat to a specific urate goal, but the rheumatologists do have a goal. They say treat to under 6 milligrams and under 5 milligrams if somebody's having tophi. That being because the tophi are seen in observational studies to have greater dissolution if you treat to a lower urate level. Urate lowering therapies. Well, it's coming back to my bathtub analogy, or I should say curbicider's bathtub analogy. You can use allopurinol, which is our first line agent, or febuxostat, which kind of stops or mitigates overproduction of uric acid. Probenecid is good for draining out the uric acid. It works on the kidneys. And our last line agent is pegloticase, which is like a bucket. It scoops out the uric acid. It's a urate oxidase. So allopurinol is our first agent, first line. It works by being a purine analog. Don't have to worry about that. It's like my trivia. Usually start them at 100 milligrams and then double the dose every 4 to 8 weeks until you get below that uric acid level of 6. I'm just deciding to follow the ACR guidelines as opposed to ACP. That's what I personally do in clinic, and I don't know, it helps me to have like a number to treat to, especially if I'm titrating a dose of medication, because I'll check every time I'm adjusting the dose of the allopurinol, I'll check the uric acid level. You can use it in people with low GFR, but you need to start them at 50 milligrams. It's pretty cheap. 30 tablets will send you back like $5. But of consideration, you need to check if they have HLA-B 5801, because giving allopurinol to somebody with that allele has a high risk of Dress syndrome, that severe allergic reaction. And the HLA allele is present in like 7.5% of Asian, Southeast Asian descent, and in about 4% of African Americans. Otherwise, side effects, GI issues, headaches, and it also has an effect on reducing the metabolism of azathioprine if you're giving those medications together. Another agent is febuxostat, works basically the same for all intents and purposes as allopurinol and is not inferior. It's a little bit more expensive. 30 pills, like in my research, will set you back more like 30 to 80 bucks. Its effects are more on, LFTs, so make sure you get a baseline LFT level. And it has shown in a couple studies to be more effective on people with CKD, although they didn't really factor in titrating the dose, escalation of the dose in those couple of randomized controlled trials. Why don't we use febuxostat all the time? Well, there has been studies of it causing a higher number of adverse cardiac events and all-cause mortality when compared to allopurinol. So it's kind of got labeled with a black box warning. So you really only want to use febuxostat in people who can't tolerate allopurinol, those HLA-B20, HLA allele carriers, or who had side effects to allopurinol. Uric agent is probenecid. It blocks the renal tubular absorption of urate. Second line in people who have relative underexcretion, or it can be used in combination with allopurinol or febuxostat. Dosing is put there. I know I'm short on time, so I want to keep it going. Side effects of probenecid are just rash and GI issues, but really big disadvantages are can't use it in people with kidney stones. You're literally making them pee out the urate, so you're going to trigger a kidney stone if they're prone to getting urolithiasis. Can't use in CKD. You need some baseline functioning of nephrons in order for probenecid to work. You need to make sure they're hydrated, and it does interfere with certain other medication excretions like aspirin, methotrexate, and dapsone. And when in doubt, our last line agent is pegloticase. It's an artificial urase, a urate oxidase, turns urate into allantoin. It's very effective, but it's an IV therapy and super expensive. This is going to say, looking online, if you were to pay for pegloticase out of pocket, it costs like $30,000 for like a milliliter of this stuff. It's not without its reactions either. You can have infusion reactions, allergic reactions, nausea, vomiting, diarrhea is dose dependent. The infusion itself takes a couple hours, so that really sets you back to be in an infusion center for that. And over time of getting repeated pegloticase, you can make antibodies to it, which make the medication not work. But those are our urate agents. And a word on prophylaxis. Whenever you're starting a urate-lowering therapy, you are at a higher risk of gout flares, usually for the first 3 to 6 months. So you'd want somebody to be on a prophylactic medication for that time, or usually like 3 to 6 months, or you can check the uric acid and see that it's at goal less than 6 after like 3 months, and then can stop the prophylaxis. Your options for prophylaxis are either colchicine, the lower dose, only the 0.6 daily to 0.6 BID for about 3 to 6 months. You can use naproxen. Remember, you're using this for an NSAID for at least 3 months, so don't forget your GI prophylaxis. You can consider prednisone, less than 10 milligrams, but remember, glucocorticoids will have can have long-term effects if used on this kind of level. So use that as your last resort in people who, can't take colchicine, have really bad peptic ulcers. Just don't throw people on prednisone. Preaching to the choir, I know, but this is my intent for this one is I want you to take a screen cap or refer to it later, because 9 times out of 10, you see somebody with gout, typically they have some co-occurring disease, and this is me kind of laying out for you, make it a little bit easier what you should avoid as far as medication for acute flares and urate-lowering therapy and like CKD, GI disease, and CHF, and what you are the better options to use. So that's my gift to you, so you don't have to do the update digging I did. Then here's another one that I ripped off of, basically borrowed with attribution to AMBOSS of a nice flow chart of gout attacks, how to treat, and how to treat them. But it's basically a nice succinct summary of everything I've talked about. So in summary, just points I want to make. First, that hyperuricemia is the number 1 risk factor for gout, and that we can only solubilize to a level of like 6.8 uric acid. But hyperuricemia by itself does not mean you start gout treatment. You need to make sure somebody has a flare before you're starting to treat this as real gout. The first step to stopping a gout flare is modifying the risk factors, diet and alcohol, adjusting that. Spotting a gout flare usually is going to be monoarticular, and in the first MTP, that podagra. Arthrocentesis is the gold standard, but you can use clinical diagnosis if you're not worried about septic arthritis. Maintain urate-lowering therapy if initiated before a flare. And if somebody has never had urate-lowering therapy before, make sure to start them on prophylaxis with colchicine or NSAIDs for at least 3 months when starting your allopuranols or febuxostats. And the target for that therapy by rheumatology guidelines, at least, is less than 6 for urate, or less than 5 for urate if they have tophi present. This is my resources. Thank you for listening to my TED Talk.
Andrew, there's 2 questions in the chat. One is, how often do we check uric acid levels?
Yeah, so definitely whenever you're titrating the medication. I also saw some in some papers recommending to check that like about every 6 months to a year. Keep in mind that those are more tailored to the ACR guidelines, what rheumatologists, how often rheumatologists think that we should be checking it. American Academy of Physicians just says treat it until you don't have symptoms. So it's really up to you, your clinical gestalt. I like having a number personally. And if you're titrating the medication, if I'm going up on my allopurinol, I want to know that it's working and that I'm hitting my goals. So as somebody who's also interested in rheumatology, I'm biasing myself to what the rheumatologists say. And then
Yeah,
Becca,
can you say, I started allopurinol today. Is it 2 weeks? Is it 4 weeks? When should they get labs?
you're gonna do every 4 weeks because every 4 weeks is when you would titrate the allopurinol. Sorry, Will. And then I see a question: if somebody started allopurinol, to stay on it for life? I had to send me something on my panel. Who came into me stable allopurinol for many years? Can't remember us flare. So I don't have like a guideline for you. I will look this up myself and get back to you. I don't want to just feed you something I don't know. I've had patients on my panel before who just kind of stopped taking their allopurinol, and I'll check what their uric acid levels are, and if they're not having a flare, I'm usually okay. We're okay to go forward. But that's Andrew doing medicine. That's not what the experts say. So just want to caveat that.
Andrew, you are an expert.
Too kind.
Andrew, great job. I was just curious, do you kind of have any thoughts about when you would send a patient with a gout flare to like the ED or consider them for like an admission?
Yeah, so definitely if they have a lot, I would consider them for admission if I'm thinking that first, any possibility of septic arthritis, I'm sending them to the ED, because even if I got the sample, I'm not ortho. What am I going to do about it in a clinic? Second, if this is a person who hasn't really had good response to like colchicine or NSAIDs or what have you, and I'm thinking, hey, you're going to need something like an anakinra, I'm sending you to the ED for admission. And that can not just be because they haven't responded to the colchicine or what have you, but because they have really bad like CKD 4 or 5, they have congestive heart failure, they have all these risk factors where I am unable to use those medications, and I need somebody to achieve relief. Sure, you can use oral prednisone, but if at all having a suspicion that this might, escalate, for me, that's like usually like septic arthritis. I'm sending them to the ED. Don't think I see more questions. Yeah, and I can raise magic.
Thanks so much, Andrew. Bram says that he has smart phrases that you can find. And for the interns, the link, I posted it on the chat. It's for the intern core conference with Mac. You can also find it on the email that I sent, and Mac might have sent a different email. But thank you so much, Andrew. It was an amazing presentation, and there's a lot of great comments. Everyone enjoyed your presentation.
Thanks, guys. Really fun to do it.
Karen, when you hit stop record and when Zoom closes, what will